All right, so today we're going to talk about tick-borne illnesses in the United States. So here are the objectives. And here's the target audience. It's really all clinicians. Here's our disclosure statement. We have nothing to disclose. And we're going to start with this slide. So this slide is showing the diseases that we're going to discuss today. So there are a number of things that we're going to discuss, and it's important to realize the geography of these tick-borne illnesses. So the geography is important. So it's not only where the ticks are located. So each of the different types of ticks that can transmit these illnesses are have a different geography, but also the diseases themselves have this kind of unique geography to each one. Let's see, I'm going to grab something here. Sorry, just a second here. There we go. Okay, and so you can see that some of these overlap. So you have Lyme here, Borrelia burgdorferi. So Lyme can overlap with Anaplasmosis, with Babisiosis, and we'll talk about the importance of that overlap a little bit later, because some of the ticks can actually have two or more of the diseases. And so a person can have a co-infection. And we'll talk about the importance of that a little bit later, but the geography here is important. And so ticks that commonly bite humans. So here, Ixodes scapularis is one of the most popular, one of the most well-known. And you can see the different sizes here. And they have kind of their scientific name and then the common name. So this is the black-legged tick. I am by no means a tick expert, but there are many different types of ticks. And so if a person is bitten by a tick and they realize that they have a tick that's engorged with blood, it's important for them to, when they take it off, to actually try and bring it with them to when they see their clinician, so they can identify the tick, if it's the type of tick that can transmit the illness that they're worried about in their area. So here you have the different types of ticks, and you have them in different stages here, an adult male and adult female. And so if you're in an area with ticks, it's important to kind of, if you're bitten by one, to realize what is in your area. And these ticks can get quite large. And so here are the different, they've been attached to volunteers, and they record how long they've been attached and how long it takes them to get large with all of this blood. And this becomes important when a patient comes in and shows you the tick, or the patient is worried about how long it's been attached for. And the time can be important. And here at the bottom left, this picture is, I believe it's a deer, with showing all of these ticks that are attached to it. So animals can have thousands and thousands of ticks on them. I think there was a report of, I think it was an elk or a moose having 90,000 ticks on it or something. It's just incredible how many ticks they can have attached to them. And ticks are generally found near the ground. So they climb up on a leaf and a blade of grass, and they kind of just put their arms out and wait for somebody to pass by. They can't jump, they can't fly. They kind of just crawl up and wait for someone to walk by, which is, I always look at this and think, what are the chances something's going to walk by and they're going to actually attach? But they climb onto the host and then attach onto the person. And when people are bitten by ticks, oftentimes they don't know that they have ever had a tick on them. And so if you ask a patient, you want to ask them their history, where they've been hiking or camping, or where they've gone. Have they been to an area that has Lyme disease? Have they been to an area that has, which type of illness? And so that would be better than asking them or relying on the fact that they say they weren't bitten by any ticks, because oftentimes they don't know, or they would have removed it. And then, people wouldn't have any issues with ticks if they actually knew that they were bitten. So here, this is the black-legged tick. And it's important, I'm showing this picture also to show that what it transmits. So Borrelia burgdorferi, so it transmits Lyme. It also Anaplasma, relapsing fever, Ehrlichia, Babesiosis. So it transmits many things. And so the same tick or the same area can have overlapping types of infections. And most of these infections are going to be treated with doxycycline. So if you treat someone with doxycycline, you're going to be hitting a lot of these infections. So Babesiosis is kind of the, we'll get there. It's kind of a popular test question. And I wanted to also just have this slide just essentially to show what other types of ticks are out there, what other types of tick-borne illnesses. And we're not just going to be going through each one. We're going to be talking about the most common, right? But there are many different types of ticks. We're only going to be discussing the ticks in the United States with the most common tick-borne illnesses. So there are African ticks and multiple other sites. But so here's Lyme disease. So Lyme disease is first recognized in Lyme, Connecticut in about 1982. So it was named after the city in which it was first described. And the bacteria is Borrelia burgdorferi. Now, I'm in Omaha, Nebraska, and in Omaha, Nebraska, we don't have very many cases of Lyme disease. And really, if we're going to have a case of Lyme disease, the question that we'll be asking the patient is, where have they been, right? So have they been outside of Nebraska? Have they traveled to an area that has a lot of Lyme disease? Lyme disease is the most common vector-borne disease in the United States. And I think last year Nebraska had about 8 cases total. I think Missouri had about 2 cases or so. And with those patients, we want to ask them, have they traveled or have they stayed in Nebraska the whole time? And there's quite interesting case reports and case studies of people that travel. So if they travel and if they go to an area that has a lot of Lyme disease, and then they go hunting and they shoot a deer, and then they bring that deer back to their location, so they're bringing those ticks as well, right? So there are quite interesting case studies out of, I believe they're Michigan and Wisconsin, or where they've had those reports. They're very, very interesting. And with those case reports, they would also have some studies where they would, I believe they would stop the hunters and examine some of the ticks, or take some of the ticks and see what they're taking back to their location. So when it comes to Lyme disease, there are early signs and symptoms, so 3 to 30 days after a tick bite. And then there's kind of a early disseminated and a late disseminated. So the early signs, this is 3 to 30 days after the tick bite. The fever, chills, headache, fatigue, muscle, joint aches. These are oftentimes things that people may complain about, but it's can be very confusing if patients are coming in with things that may not be pointing to Lyme disease right off the bat. Erythema migrans is the classic rash, so we'll talk more about that. Here's the picture of the rash, and it occurs in 70-80% of the infected people. It expands gradually, reaching up to about 12 inches. It can be warm to the touch, and sometimes it clears as it enlarges, but it's the classic target lesion, the bullseye appearance. And here's another picture. So these are pictures of the patients on different skin tones. And so you have the classic bullseye target appearance of the rash. Incubation period and symptoms. The period is 3 to 30 days. You have a localized stage, so you have erythema migrans, which is the picture. It's a red ring-like expanding rash. Classic rash is not present in all cases, so you can't use it to say that they weren't exposed or they don't have Lyme disease. And sometimes they don't notice it. They don't see that they ever had the rash. If they were bitten on their back or they're bitten on the back of their knee and they just never notice it, that's another possibility. Now, flu-like symptoms: malaise, headache, fever, myalgias, arthralgias, lymphadenopathy. And this is the early stage. And Lyme disease may be diagnosed clinically in patients who present with the rash. So if they present with the rash and they were in an area of high prevalence of Lyme disease, then you can treat them without doing any kind of testing. So serologic testing may be insensitive at this stage. And for us, when it comes to tests on the subject, this is one of the things that's one of the classic test questions. They'll say, patient comes in with a Erythema migrans rash. They were in an area with Lyme. They just had a holiday and they were in Lyme, Connecticut. And what do you do next? And then you would just want to treat them. And you wouldn't do any kind of serologic testing or any testing at all. It would be a clinical decision to treat them. And one of the reasons it's a popular test question is because it's one that clinically, that when they go see a clinician, they may be tested and their tests will be negative. And then sometimes they're told, well, they don't have Lyme disease because their tests are negative. But if they come in with a classic rash, you'd want to go ahead and treat and not do any testing at all. And so here's a picture of a patient with the bullseye lesion here on their back. So they were bitten by a tick in a place that has Lyme, and they never noticed it, and it stayed attached. And this rash, if they don't examine their back after they've been out in the woods or out camping and look for ticks, they may never know they were bitten and they may have the rash and never know that they had the rash unless they notice it themselves or someone notices it for them. But the onset is 3 to 30 days after the tick bite. Skin lesion can be unnoticed, minimal pain, right? So if they had pain, they would have noticed the rash, and resolve without therapy over weeks. So if they're bitten and they don't receive treatment, the rash will go away. But not all of the rashes look like the target, the classic bullseye. Only 20 to 30% of the erythema migrans are classic target lesions. They can have a rash that doesn't look like a bullseye, but can still be Lyme disease. So these are some examples of rashes that are not the classic type of rash, but they were confirmed Lyme disease. And the laboratory findings in general are not very helpful. So they might have an elevated ESR, LFTs, but not helpful. So Lyme disease has some controversy around it, which we'll discuss. But part of the issue is that when you have diseases that are controversial, a big part of it is that the testing is poor. So the quality of the tests are either not done correctly, or they're just not very good tests, which makes for a controversial disease. And here are the later signs and symptoms. So days to months after the tick bite, you can get severe headaches, neck stiffness. You can get a Lyme meningitis. You have additional rashes covering other areas of the body, which we'll see a picture of. You can get facial palsies, arthritis. So really, you can see that they can present in so many different ways. And so presenting in so many different ways and having all of these issues along with poor testing is what kind of makes it a big topic for having controversy. So here you have Lyme disease. So you can see this patient here on the left has kind of rashes all over, disseminated rash of Lyme disease, and so the early stage, or the early erythema migrans bite, and then you have this would be You could call this an early disseminated or late disseminated. This is essentially a disseminated Lyme disease here with, they just get rashes all over and multiple rashes. They can have flu-like symptoms. And so here's a good example of, here's stage 1. So you could say this is early infection, Erythema migrans, bullseye rash, starts at the site of the bite, slowly spreads. They can have myalgias, arthralgias, and then stage 2, or you could call this early disseminated. They have reoccurring Erythema migrans, which would be rare, or you could have, and you can see this patient has kind of rash, kind of all over. Neurologic problems, meningitis, neuritis, heart problems. As you could have a myocarditis, you could have first, second, or third degree heart block. In our, I know in our boards, infectious disease boards questions, they'll ask about a patient with third degree heart block, and then you'll find out it's Lyme disease, and then you'll try to prevent the patient from leaving with a cardiac device, a pacemaker. Really, you want to treat it aggressively while they're inpatient, and if they get treated really well, then they won't need a pacemaker. And neuritis often presents as peripheral nerve palsies, like this patient here. You can see his cranial nerve palsies. And then stage 3, which is you could call it late disseminated. And with these stages, you can have overlapping with early disseminated, late disseminated, but months to years later, the patient can have arthritis, they can have chronic neurologic problems, and this is all really from being, these patients had Lyme disease and were untreated Lyme disease. And I wanted to include some slides with just essentially showing the many different ways that Lyme disease can manifest itself. You can have rheumatologic issues, you can have keratitis, uveitis, hepatitis, neurologic issues, cardiac problems. So it can come out in many different ways, which can be an issue with diagnosis. And early diagnosis and treatment is key to preventing long-term complications. So here on the top, you can see the Erythema migrans, the rash, and then on the bottom, you have your lab tests and spirochetemia, IgM, IgG. And this is important to see that you have the IgG that shows up and then goes away, and then your IgG stays, essentially can stay forever, right? So it's with serology. So one common question that patients will have is, once they're treated, they'll say, well, how do I know it's gone? Or can you test me to make sure that I no longer have Lyme disease? And with serologic tests, you know, the IgG can stay there forever, and the IgM will form and then go away. And if you're testing a patient, if you have if you test them with IgM and IgG, and the IgG is negative and IgM is positive, so that's most likely a false positive. And so when you test someone that was exposed greater than 30 days, they'll say IgG Western blot only. And the reason for that is to try to minimize a false positive test with only the IgM being positive and the IgG being negative. So I kind of skipped ahead a little bit here. So I'll go back. So this is the 2-tiered testing system for Lyme disease. So there's a 2-tiered system. So you start out with doing an enzyme immunoassay, and if that's positive or equivocal, then you can go forward and you can consider testing serology with either IgG and IgM or IgG alone. And so if it's less than 30 days, so if you're expecting them to have IgM present, then you would test both. And if it's late, if it's been longer than about a month, if they're presenting 2 months later and they say, I realized that I went to Wisconsin and I've been feeling okay, but all of a sudden I'm feeling these symptoms that are consistent with Lyme disease, or they were in an area with Lyme disease and they know they were bitten by ticks, then it would make sense for testing, but you would test that patient with IgG only and not IgM. And that's the reason, is because if you test with both and IgM is positive and IgG is negative, then you most likely have a false positive. Now, if you have the immunoassay and you get a negative result, you can consider an alternative diagnosis. If the patient with signs and symptoms is consistent with Lyme disease for less than 30 days, you can get a convalescent serum. So that would essentially be testing for serology later. So if you think it's early, if they have the Erythema migrans rash, you would essentially just treat. But if you think it's too early for them to have serology yet, be positive, then you can either treat or not treat and check later the convalescent serum. And this is essentially what we just discussed. So the serologic tests are insensitive during the first few weeks because they have not yet developed antibody. During the stage, patients with the rash may be diagnosed clinically. And a positive IgM test in a patient with illness duration more than a month is not reliable. So that's the false positive test. And due to antibody persistence, you can't use serology to determine if they've been cleared of infection or active or present infection. And I want to say a word on tick removal. So when patients remove the ticks, the recommended thing to do is just take some tweezers, grab the tick as low as possible, and remove the whole tick at once. And they recommend doing this because if you grab the tick by the back, then when it's removed, the head may stay in the skin and you may essentially just pull the tick in half. But this is the recommended method. You just essentially take some tweezers and pull it out. So kind of trying to recommend not doing these folklore remedies of people will say, well, I don't want to pull it out, I'm going to smear it with peanut butter, right? So they'll say, if I smear it with nail polish or peanut butter or something, it'll suffocate and fall off. So I don't recommend doing any of those things. Just take a tweezers and pull it out. People will say, well, if I take my lighter and I heat up my lighter or heat up like a needle or something, and so people will come in with burns from their lighter where they were trying to burn off the tick and they burn their skin. So just essentially pull the tick out. So here's an example of an embedded tick, and they grab it and they just pull it out. And here, how to remove a tick, this is the same type of thing. You just grab it with the tweezers and pull it out. And then they recommend taking the tick and bringing it into the emergency department so you can, or into your doctor next time you see them, and essentially just showing them the tick and saying, this is the tick that bit me. Is that, what type of tick is it? They can identify it and kind of go from there. So early disease is going to be doxycycline. Cardiac or neurologic issues, ceftriaxone for 21 days. Lyme arthritis, you can do doxycycline for 28 days. And here I have the question, does chronic Lyme exist? So this is also part of the controversy. So Lyme disease kind of attracts people that are interested in cover-ups and think that the medical establishment is lying to them or trying to trick them. So we'll get patients in the clinic that will come in and they'll tell us that they have Lyme disease. And I've seen patients where they've been diagnosed with another illness, but they won't believe it. And there are many websites on the internet that are, I'll say, not mainstream, that have kind of conspiracy theories of that doctors cannot recognize Lyme disease and it's a cover-up, and it's all kind of big business tricking people and telling them that things don't exist. So chronic Lyme disease is something that people will say that they still have the bacteria within them, but it's not treated long enough. And there have been many studies that are very good showing that the bacteria has been killed, and the patients can actually have sequela of the infection long after, and it may be months or years or forever, but it's sequela of the infection that lasts longer than the infection. And there are other examples within infectious diseases that you can have problems long after the bacteria has been killed. So there can be sequela of Lyme disease, but chronic Lyme disease, as it's been kind of described by websites or by patients, doesn't exist. And one of the reasons it's controversial is that politics gets involved. And so, and even just recently, I think in February, Arizona, in Arizona, they tried to vote on it, saying that chronic Lyme disease does exist and it should be treated longer. And so when politics gets involved, they're voting on it instead of using scientific criteria. And so every year at our infectious disease conference, there are people protesting with chronic Lyme disease posters saying that Infectious Disease Society of America has a monopoly, and that they have a monopoly on what is and is not a disease. And so, but there are definitely sequela of Lyme disease that go on for that people have issues with. Now, treatment for Lyme disease. So treatment is doxycycline is the first line treatment. There are also other treatments that are available, but doxycycline is really the best thing. And as far as duration, erythema migrans you could treat for 10 to 21 days. Neurologic disease is two weeks. You use ceftriaxone for 2 weeks, and then cardiac or arthritis is a bit longer. And prognosis depends on the stage of the infection. So you want to make sure that you treat it early. Another issue with this is that if a person's treated, but they remain in an area that has a lot of Lyme disease, you could get it again. And so it's important that if you're exposed to get treated. And here's some common questions for Lyme disease. So prophylaxis is given for outdoor activities such as hiking and camping. And the answer is no. And so this question would be, if a patient comes to you and says, I'm going to go to Connecticut for this and be there for the summer, and we're expecting to be going out and going camping, can I take doxycycline for the next year? Like, I'm going to be in Connecticut for a year, can I just take doxycycline every day and then I won't get Lyme disease? So the recommendation is not to do that. The recommendation would be to try and prevent tick bites, and after you've been out camping or hiking, go home and look at yourself, look all over, try and inspect your children, make sure that they don't have any ticks that are attached, but not to be chronically on doxycycline. If a patient presents with erythema migrans, do you check Lyme serology? No, you just treat. So you don't need to check them. It's too early for them to develop antibodies. You just, they come, they have, the story is consistent with them being in an area with Lyme disease, and they have the rash, you just treat them. If a patient presents with fatigue, joint stiffness, and muscle aches, do you suspect Lyme disease? So the answer here is no. So do not check Lyme titers, don't treat based on non-specific findings. So one of the reasons there are so many false positives is that people will come in and they'll be from this, like, for instance, in Nebraska, if they haven't traveled anywhere and they come in, they say, my knee hurts, my knees just started hurting a couple weeks ago, I think I have Lyme disease. And I had a patient like that, and I asked, why do you think you have Lyme disease? And they say, because my family member tells me I should get Lyme checked. And if they haven't been in an area with Lyme disease, if they have a positive, it's most likely a false positive. And scenario 4, for patients with a history of outdoor activities or tick bites, if they have an exposure in an endemic area, you do a 2-tier testing. So that's the 2-tier testing that we discussed. Now, when people talk about tick bite prophylaxis, they may talk about, I'm going to an area that I'm going to go camping, can I take it? But another way that prophylaxis is discussed is that antibiotic treatment following a tick bite. And it's not recommended it's not recommended unless, and there are some, uh, here's the unless. So if they've been to an area with Lyme disease and they don't have a reason not to take doxycycline, the attached tick can be identified as Ixodes scapularis, is the one that has Lyme disease. It's been attached for greater than 36 hours. So if the tick is still small and it's not engorged with blood, if it's very small and they say they just went hiking, they have a tick attached for 30 minutes or a couple hours, and they go home and they take a shower, they realize they have a tick and they take it off, then you wouldn't need to take any doxycycline. Prophylaxis can be started within 72 hours of the tick removal. So if a patient comes in and says, I was bitten 2 weeks ago by a tick, and they want something, it doesn't really fit. And Lyme disease is in an area that they have, or they went hiking in an area that has Lyme disease. So this is a different type of prophylaxis. This is the other prophylaxis we were discussing was before they are bitten by a tick or before they have their holiday. And then here, it's after they've already been bitten, and it's consistent with a tick that's been attached for greater than 36 hours, and it's the right kind of tick. Okay, so moving on to anaplasmosis. So anaplasmosis, here the geographic distribution, you can see where it is, and it's in the areas that are also areas that have Lyme disease. And due to the common vector, you can have co-infection with anaplasmosis, and this is Borrelia burgdorferi, this is Lyme, Babesia. So these are because the same tick can transmit several different types. And the thing that distinguishes these different types of infections are what cell types that they're found in. So anaplasmosis, here's the bacteria. It's a tick, incubation period 5 to 14 days. The signs and symptoms, oftentimes the signs and symptoms, the clinical, how the patient presents clinically won't be enough to distinguish one from another. And the exam, also again, not very helpful. So the best way to do it would be to get a peripheral blood smear and ask the pathologist to review. Now, getting a peripheral blood smear, the sensitivity is not great. So if it's not seen the first time, you'd want to actually get a couple of them. I know some pathologists that don't really like this because they say it's not, the sensitivity isn't very good, but if you're suspecting it, it's the best way to diagnose it. And here again, we have a morula and a granulocyte. In the labs, they can have mild anemia, thrombocytopenia, leukopenia. The diagnosis is the presence of the membrane-bound vesicles filled within the organisms, the morula, in granulocytes. And this is what I was saying. The blood smear is not very sensitive, and you can't use it to say that they don't have it. You can also do PCR tests of whole blood. That would be a send out, or serology. And serology takes some time. So whenever things take time, people don't like waiting, and I wouldn't like waiting either for for a serology test to come back if I'm not feeling well. And doxycycline, so you would treat both Lyme disease and anaplasmosis with doxycycline. And here again, you have the morula in the cytoplasm of the granulocyte. And so you can see the morula here. And the treatment, doxycycline. So adults or children, the treatment is doxycycline. And people will say, well, I don't want to give doxycycline to children. And we'll talk a little bit more about that later, but the big campaign now is that doxycycline saves lives. And so they have pictures, and they have pictures with children showing their white teeth, because the concern here is that doxycycline is going to stain their teeth. And so the campaign, they have children smiling, showing their nice white teeth, and that they're alive because the doxycycline had helped them. And so we'll talk more about that in just a minute, but doxycycline is the treatment of choice. Now, Babisiosis. Babisiosis, you can see, has the, this is a parasite, and it's going to be up in the same location as well. Incubation period is 1 to 9 weeks, and fevers, chills, sweats, myalgias, arthralgias, again, it's not very, the signs and symptoms, hard to distinguish. Now, dark urine and splenomegaly. Now, here this is going to be, these are in red blood cells. So here you can see the, it's in a red blood cell. So when they do the peripheral smear, that's how you would diagnose it. They can have hemolytic anemia, so it's the red blood cells are breaking apart, thrombocytopenia, elevated creatinine, BUN, LFTs can be high, and identification of the parasite in the peripheral blood smear. And this could be taken, you know, the differential diagnosis would include malaria for this. So it can look similar to malaria, but they haven't traveled to any areas with malaria. And you can see the rings in the red blood cells. Now, and here, as far as treatment goes, this one is unique compared to the others. So the treatment here is not doxycycline, it's atovaquone plus azithromycin. And so if the popular test question would be, you have a patient that comes in, they have another tick-borne illness, you treat them with doxycycline and they're still sick. And then you have to suspect babesiosis in addition to what other tick-borne illness that they had. And the reason is because the treatment for this isn't doxycycline like it is for all of the others. The treatment is different. And for that reason, you want to also consider that they have 2 tick-borne illnesses within the same patient. And I think there was a patient recently that was just fit this exactly, which is, you know, it would make perfect test question. So that patient read the textbook. And here we have Erlichiosis, and you can see the geographic distribution for this one is a little bit different. It's not as high up as the others. So Ehrlichia, it's a tick-borne illness, incubation period less than 2 weeks here. Signs and symptoms, again, not very helpful. And as far as distinguishing it from the others. And now we have a different cell type. So we have a monocyte. And I know in my internal medicine boards, they went through these and they had different morula and different cell types asking which infection was it. And you can have thrombocytopenia, leukopenia, you can hepatic transaminases, and the morula can be detected in about 20% of patients. So you wouldn't just get one peripheral smear and say that's it, that they don't have it. But the treatment is also doxycycline. So adults and children, doxycycline. And again, here, doxycycline saves lives. And Rocky Mountain spotted fever. So now you have North Carolina, Oklahoma, Arkansas, Tennessee, makes for about 60% of the cases. And so the clinical presentation, they have a tick bite, abrupt onset, fever, headache, myalgias, rash. So this is essentially the same type of symptoms except worse. So this is worse than the others, and this would be a reason that you'd want to or need to suspect it and treat it early. So here you have the early signs and symptoms: high fever, severe headache, malaise, myalgias. They have edema around the eyes, back of the hands, nausea, vomiting, and late altered mental status, coma, respiratory compromise, and necrosis. And another thing that is really made about this is the rash. That's a centripetal rash that it goes from the ankles and the wrists and the wrists to the trunk. So it first starts peripherally and then moves centrally. In Rocky Mountain spotted fever, the rash typically appears 2 to 5 days after the onset of symptoms, And this is important. 10% of the patients never develop a rash. And so that's a popular test question, because oftentimes people will not want to diagnose it, and they won't want to treat because they'll say, well, Rocky Mountain spotted fever, they don't have the spots, they don't have the rash, and they won't treat because they don't have a rash. But really, the decision to treat should never be based on the presence of a rash. So it's better to give doxycycline and then kind of try and sort it out later. And there can be a lot going on when the patients first present, trying to sort it all out. So early rash and can appear on the wrists, the forearms, and then spread to the trunk. And they can have a late rash, and it can get really bad. So it's important to think about Rocky Mountain spotted fever. Give doxycycline early for anybody that's sick or becoming sick. They can get thrombocytopenia, elevated hepatic transaminases, hyponatremia, and the diagnosis, demonstration of a fourfold change in IgG. And really, if they're sick, you don't want to wait for serology. Serology is really, a lot of the times it's used for research studies only, and not so much, it can be, and what I mean by that is you don't want to wait until it's positive. If you're suspecting it, you'd want to treat early. And then detection of the DNA in a skin biopsy, or staining, and the treatment, let's see, is doxycycline. And we'll talk more about that. But here you have more of the rash, and then it's showing the peripheral rash moving centrally. Yeah, confirmation diagnosis based on laboratory testing, but you shouldn't delay and wait for testing. And so adults and children, it's doxycycline. And then this is from the CDC. They have lots of these pictures smiling, showing their white teeth. Now, research on doxycycline and tooth staining. So this is, I find this to be interesting, because the background here on doxycycline and older tetracycline antibiotics, the tetracycline antibiotics first used in the 1940s, older tetracycline class antibiotics have been linked to the cosmetic staining of their teeth when used in children before the age of 8. As a result, in 1970, a warning label was attached to all tetracyclines against the use in children under 8 years old. And because everybody is taught this in their training of not using doxycycline in children, it prevents children from getting the doxycycline when they need it. And so doxycycline was introduced later, but doxycycline, the warning carried over to doxycycline, right? So it wasn't shown to happen with doxycycline. It was essentially just the class of antibiotics, the tetracycline class. And so for that reason, we have things like this, where the case fatality rate, and then it's so much higher in younger age group. So age 0 to 4, it has such a higher fatality rate because, and the thought is that they're not getting doxycycline because everybody's been taught not to give doxycycline. But Rocky Mountain spotted fever is so bad that you'd want to give doxycycline early. And when they recently done studies with giving children courses of doxycycline, and they did just fine. So, and now we have tularemia, rabbit fever. So here's a Francisella tularensis, gram-negative bacillus, intracellular pathogen, and you can see its geographic distribution is more central. About 100 cases per year. I think there are more cases, but I feel like there are more cases because I've seen this one, but I guess it's more common in our area. Now, it's transmitted with tick or deer fly bites, or handling infected animals, so people skinning rabbits or skinning wildlife. This is known as rabbit fever, because you can get it from cleaning rabbits and from skinning rabbits. I saw a patient that he had a wound on his hand, and we asked him, must have been 20 times in clinic, have you been skinning animals? Do you hunt? And he kept saying no, and he was getting annoyed with us, and we decided to treat him anyway. And then he left clinic and then called us about, an hour or two later and said, oh, I did skin a rabbit. And so we were glad that we were treating him. Ingestion, undercooked meat, contaminated water, inhalation, but not peer-to-peer. So this picture up here, you can see this, it can be from a fly, the deer fly bite. It can be from a tick. And then we have a person here mowing the lawn. So the question would be, why is someone mowing the lawn here? And the answer is because there are cases where people are mowing the lawn, or they're on a riding lawnmower, and all of a sudden they go in and they're sick. And what happens is they'll run over the carcass of a rabbit, and it will aerosolize it and put it into the air, and then they'll breathe it in, and they get inhalational tularemia, which is the worst kind. And so the recommendation is to wear a mask while they're on their riding lawnmower. So the mask recommendation isn't so much for the dust as it is for preventing inhalational tularemia. And when September 11th happened, there was a big push to talk about bioterrorism. And so this was one that would come up as a test question. You have someone that multiple people that just went to a football game or a baseball game coming in with inhalational tularemia from somebody flying over in a small plane and dumping it out into the air. But this doesn't make a very good bioterrorism weapon because it's not person to person, so it doesn't spread as easily. And here are all the different ways that people can get it. So you also glandular, oculo, so it can go in through the eye. They can get it. There are case reports of people pulling out a tick, and they squeeze the tick, and it pops and it gets into their mouth, and then they get oropharyngeal tularemia, pneumonic, which is the worst type, and typhoidal. So there are multiple different ways that you can get it, and they can come in feeling bad. And this is the classic picture of the hands from skinning a rabbit and cutting themselves, or children are bitten by deer flies and come in like this. So you have ocular here, you have on the skin. And laboratory testing, now if they have a good history, you can just treat, or you can look for a PCR or try and culture it from a wound if you have a wound. And the treatment here, you can give doxycycline, or if they're severely ill, streptomycin or gentamicin. And so that's going to conclude our talk on tick-borne illnesses. I think we're right at time. We do have enough time for some questions if anyone has some questions. But thank you very much for joining for this talk. I find this a very interesting topic. I think that tick-borne illnesses are quite interesting. I think as the tick locations and the geographic distribution of the ticks move, the illnesses can move with them. And with climate change and with things warming up, the ticks are patterns and the location of things like mosquitoes can move. And so if things are as everything heats up, the distribution of the ticks may continue to move north, and I think that's one of the things that makes infectious diseases interesting. So there's a question: can we get a copy of the slides? Yes. So we will make the slides available to anyone that likes them. We can certainly send them out. Yeah. All right. Well, if anyone has any questions, please email me any questions that you have, and I'll be sure to email you back. All right. Thank you very much, everybody. All right. Am I good to stop the recording? Yeah, let's see. Stop recording.